Well, it is 7 o'clock, so we'll go ahead and get started. Good evening to all of our participants. We're delighted to have you here tonight. This is the first talk in a series, in a Women in Health series, that is brought to you by Cleveland Clinic Abu Dhabi. Our first topic today will be the very important, crucial topic of gender equity in healthcare. And I am delighted to have my co-host here with me, Dr. Salsan Abdelrazig.
Hi, I'm Sosan. I'm a consultant hospitalist at the Cleveland Clinic Abu Dhabi, and I'm also the chair of medical education. So I'm excited to be with you today.
And my name is Dr. Pascal Anglade. I am a gastroenterologist at Cleveland Clinic Abu Dhabi, and I also serve as the Director of Physician Experience for the hospital. This being 2020, we are appropriately physically distant for a conversation which I hope will bring a lot of value to you tonight. So we really appreciate you being here. Is it a men's world out there? It is a men's world out there. It really, truly is. And how do I know that for a fact? Well, it's because we see it in everything that we do. And I love this first slide because it really shows you sort of gender inequity in everyday things that we use. The first one would be the lapel mic that is impossible to pin on a dress when you give a talk, when you give gun rounds. You cannot wear a dress if you wear a lapel mic. Voice recognition software, which has been shown in study to be 70% more accurate, recognizing male speech compared to female speech. Phones that are getting bigger and bigger when we know that the average female hand cannot handle those very large phones that are coming out now. And although I'm pretty sure they cannot get any bigger because I think they've actually reached the maximum palm size for a man. So I think we've maxed that out. But we also, as healthcare professionals, think about medical devices that we use on a daily basis that were really not designed with women proceduralists and surgeons in mind. And what does that lead to? Repeated, more injuries due to repeat use by our proceduralists. So these are all things that we have to think about when we see, we go out into the world. But before we go on more with our talk today, I think it's really important for us to clearly define what we mean when we say gender. And what I want to be clear about is that we are not talking about a man versus woman, a male versus female type of adversarial situation. When we talk about gender, it's really all the attributes and the activities, the behaviors that a society considers appropriate for a certain group of people. This is what we talk about when we talk about gender. And what typically happens when you have those genders is that it creates some level of a power differential between genders. So this is what we want to talk about to you today. So this is the lens that we want you to use for our entire talk today. And think about gender really as yet one more social determinant of health that we have to consider.
Right, I think that's really key. It's a key point that we're looking at it from a systems level and specifically as it determines health outcomes. Right?
Absolutely, absolutely. So using that lens that you're going to keep in mind, let's delve into a reality that has been ours since the beginning of the year, which is namely the COVID-19 pandemic. So the COVID-19 pandemic has consumed our personal lives or professional lives for almost the better part of the year. And one of the issues that has been a recurrent one with COVID-19 has been the use of PPE, which is personal protective equipment. Now, personal protective equipment is crucial to protect healthcare workers or frontline workers from getting infected. But what happens when your mask doesn't fit, when your goggles don't fit? It increases your risk of getting infected, right, and getting COVID and potentially getting sick and even dying. So what have we learned here recently is that PPE is not made for women. It's not designed for women. Whereas the other design inequities that I mentioned before were perhaps mere annoyances, this is actually life-threatening. If your PPE does not fit you, you may get infected. Now, PPE has traditionally been designed around the 70-kilo man, right? And this is where the flaw is. And this we've known for years in multiple industries, engineering, construction, police, NASA spacesuits. We've known for years that PPE really has not been designed with women in mind, and it puts women in greater danger.
It says, and that says a lot, right? It says a lot about sort of the value system of a culture where half, at least, and in healthcare, more than half of its professionals are women, and yet they're not taken into consideration when design
such important pieces of equipment. Absolutely. So since we're already talked about the pandemic, I think it's important to stay on the topic for a bit and sort of examine all the ways in which this pandemic has truly, essentially exacerbated a lot of the inequities that were already in our system. It just made everything worse. And we can go around that diagram to understand how that happened. The first question that I asked myself is, well, who are your essential workers? Who's your workforce that's going out there every day? And we certainly know that for healthcare, essential workers are majority, 60, 70%, depending on where you are women. So they're the ones who are going to be at the front line and definitely more impacted by the pandemic, right? Who cares for people when they're sick? Who cares for you when you're sick? Who cares for your community when people get sick? Typically, again, women, putting them, giving them more work and putting them at more danger of getting infected themselves. When we talk about domestic violence, this is something that has been reported in many different countries because of the confined nature of our lives. Now, everybody lives together in confinement. Violence has been much more frequent, with the typical victims being women as well, right? When we look at politics, who used to make decisions before the pandemic? Typically men. Who makes decisions during the pandemic and this crisis? Typically men. And what happens when men make decisions without the input of women who are disproportionately affected by that pandemic? That's the question that we have to ask ourselves.
Right. And again, I think, as you've mentioned, the idea here is to think about how do we look at these systemic issues that are pandemic driven through a gender lens, right? Not to say, again, it's a man-female thing, but it's more, well, how do we make sure that there's equal representation on those tables, right?
Absolutely. So let me take it back a little bit so we understand a little bit more of the history, certainly in healthcare. And I love this slide because it is so simple. 1993, what does this year mean to you? It was a big year for me. I started college. It was the year that Bill Clinton took office. But it is also, shockingly, the first year that the FDA and the NIH mandated that every single clinical trial should include women participants. Up until 1993, which is not that long ago, you could run an entire clinical trial with exactly 0 women in it. And people tell me, oh, well, this must have been small studies, inconsequential study. No, these were big, large studies. The Baltimore longitudinal study, the Physicians' Health Survey, large studies that were done without any women participants. Studies that brought you recommendations like the 1 aspirin a day recommendation was done based on a trial that had no women participant. So what happens really, and the question that we have to ask ourselves is what happens when you exclude women from clinical trials? Well, the first thing that happens is that you end up underfunding diseases that disproportionately affect women, things like conditions like autoimmune conditions or reproductive health, because this is not even in your purview. You don't even think of them, right? That's one. 2, what happens? Well, you think of it. 8 out of 10 medications that were withdrawn from the market between 1997 and 2000 were withdrawn because of disproportionate harm made to women patients. Is that shocking? Well, not really, because the women were really never included in the trials that led to the approval of those medications in the first place. So we shouldn't be shocked that that's the outcome, but yet it is incredibly shocking. And the third thing that happens when you don't include women in clinical trial is that you misunderstand presentations of clinical conditions. So for example, I'm a gastroenterologist. Women come to me all the time with epigastric pain and nausea. Well, it turns out epigastric pain and nausea is a very common presenting cardiac symptom for women as opposed to the crushing chest pain. Women present with what we have been calling atypical symptoms, which turned out are typical for just the other half of our patient population. They really are typical, right? So these are all the things that happen when you don't include women in clinical trials.
Yeah. And so if we were to take all of that background and look at it from how it essentially impacts the healthcare workforce, right? I think it's important to, again, look at the data, right? So we know, for example, that women make up by far and large, across the entire world, they make up the vast majority of healthcare workers, right? And so, in this particular study, they reported about 70% makeup of the healthcare workforce as women, but in many countries it's much higher than that. And I don't think you'll be surprised to see that there's a differential in the representation of women depending on the profession, where women are more represented in nursing and midwifery when you compare them to other professions such as physicians and dentists. Now, having said that, though we make up as women most of the healthcare workforce, right? And actually, this slide shows data from the United States where you see women make up about 75% of the healthcare workforce. If you look at what the level of representation is in healthcare leadership, that 75% turns into 3%. That sort of half person that you see down there, right? And so it's I think quite a stark comparison, right? To look at that disproportion, right? So although we're on the ground day to day as women serving in the healthcare workforce, we're not sitting in leadership positions, right? And those positions, by the way, this particular study is looking specifically at executives, healthcare executives, but even if you look at healthcare academia, if you look at clinical leadership, you'll find the exact same trend, right? And so having said that, okay, well, that's something to keep in mind. We're not there, right? We're not actually physically present in many leadership tables. But I think the other really important thing to mention here is where we do work in our day-to-day, we are also not as recognized or not as professionalized as our male colleagues. So this was a really important study that came out a couple of years ago. Made a lot of noise, and essentially looked at what women have been saying for decades, actually, right? They specifically looked at whether or not there's a difference between the likelihood of women being introduced as doctor when compared to their male colleagues at a specific hospital center, as you can see here at the Mayo Clinic, and specifically at Brown Round, which is considered, of course, a pretty prestigious sort of forum, right, or speakership invitation. And as you can see, let's look at this table here. You can see when females were the introducers, right, whether they were introducing a male or female speaker, they tended to use their titles, right? So 98% of the time, 95% of the time, they essentially introduced those speakers appropriately using those titles. But if you look at when male physicians or male professionals were introducing female colleagues, they only introduced them using their title about half the time, right? Generally, they also introduce their male colleagues at a lower rate than female introducers. However, again, the difference here that we're highlighting, the statistical significance, is essentially between that male introducer's likelihood to use the word doctor when introducing a female speaker, as compared to that same person introducing a male speaker, right? So that's really, really powerful data. You might say, okay, well, people make blunders initially, and so, it may not be fair to take sort of that moment of introduction, right? So they looked at essentially also any form of address, right? During any time, right? During that particular speaking engagement, whether that female speaker was ever referred to by her professional title. And again, you can see that there's a statistical significance where she is less likely to be referred to as a physician if she was introduced by a male colleague, right?
Is this shocking to any of you? And this is where I would love, and again, at the beginning of the talk of this webinar, I mentioned that this was meant as a conversation. I want our participants to feel free to join, to put in the Q&A their own experiences, because this is something I think that truly is seen throughout, and this is not uncommon. It is so common, as a matter of fact, that a lot of hospitals and clinics have had to redesign their badges, right? The badges that we all wear every day to identify ourselves, to clarify in big letters the role of the physician, so that not only our fellow caregivers, but our patients are not confused, and recognize, that we are indeed physicians.
And that's a common story. I think many of you attending tonight would be able to share with us and say, look, how many times have you as a male physician walked into a room wearing a white coat and been mistaken for a nurse, right? Unlikely. Or mistaken for any other health professional, right? Unlikely. How many times have you as a female nurse entering the room may have been mistaken for some other professional, right? Or non-clinical staff, right? So the idea, again, is that this is something that, though has been anecdotal for decades, is finally coming to light in the literature.
So please feel free to share your experiences on the chat, and we'll come back to that later in the conversation.
Right. So it's, again, going back to how, or, what words we use in healthcare when thinking about our female health professionals. It's not just about introductions. It's also about letters of recommendation. So again, interesting data here. So they looked at essentially, we're showing you one study, but this has been replicated multiple times. They've looked at, well, are there gendered differences in how people write letters of recommendation? I think it's important, again, they did not look at whether or not that the recommender was male or female. No. This was across the board, right? And what they found is when writing letters across the board for male applicants or male trainees or male professionals, generally those letters used more words. Mm-hmm. They used more standout vocabulary, such as exceptional. They focused on achievements and specific competencies and skill sets, right? They talked about leadership traits, right? And they also used the applicant's name quite often, yeah. Right? Whereas if you look at letters that are written for female applicants or professionals, those letters by and large use completely different terminology, right? So they use less words, they tend to be shorter. They tend to use attributes that are sort of aesthetically pleasing, right? So being delightful, or even including physical descriptions, right? Using verbs that usually describe sort of grindstone traits, such as being a hard worker or supportive or a team player, right? Very, very, not as much sort of strong worded vocabulary, focusing on specific skill sets or leadership traits, right? And again, issues primarily of focusing on work ethic and so on, right? So that may be well intended, all well and good, right? But again, when you think about that person receiving the letter, thinking of you as a professional and thinking about, well, whether or not to select you essentially into that particular position, clearly skill sets, behavioral traits, and actual competencies tend to go further than sort of pleasing traits, right? And so that's again, I think this is an important point as we all, right, sit and write letters, right? And so again, and this is by both male and female recommenders. In fact, we're hoping to drive this point to you with this slide here. So we're really, really fortunate to have an example here actually provided by Dr. Abby Spencer, who is our colleague at the Cleveland Clinic at the main campus, who is a program director, and she tweeted about receiving this letter, right? And as you can see, if you look at the traits here, I mean, warm and caring, right? Twice, right? Not once, twice. And in fact, the serving with distinction had to do with her delivering her first baby, right? Which again, all well and good, but really doesn't speak to why you would want that individual essentially in your training program, right? So again, we're hoping that there's a do not use list, do not use verbiage that comes out of this talk when we're recommending trainees.
Absolutely. So thank you, Sasan. It is impossible to have a talk on gender equity without talking about the gender pay gap. And the gender pay gap is something that we have talked about for years, and it's been increasingly obvious that it is pervasive in every single industry, from movie stars to athletes. Everywhere that has been looked at, there has been a significant gender pay gap. Now, do we think we're immune in medicine or in healthcare? We'll explore that in a minute. But first, I wanted to show you some dates, which to me, again, I keep saying shocking. Right. I keep coming back, but they were truly surprising to me. So do these dates mean anything to you? March 5th, August 22nd, November 20th. If they do, please feel free to write it in the Q&A. Thank you for contributing. Put it in the chat. Tell us if those dates mean anything to you.
Hold on, let me check the
See
chat.
what people are saying. Yeah, people are
so far, nobody knows what these dates are.
Nobody knows. So let me just put an end to the suspense and let you know. So this is Equal Pay Day. Equal Pay Day is the it's a really interesting concept, is essentially how far into the year a woman has to work to earn as much money as a man doing the same occupation made by the end of the prior year. So it's how far into 2019 a woman has to work to earn as much as a man made by the end of 2018.
Right, and the operative word here is same job.
Same job, right?
Same hours, same skill set.
Apples to apples, right? Same. So there are multiple dates here because this is US data, and what they did is that they separated different groups. So March 5th is for Asian American women. This is how far they have to work into the year. This was 2019 data, to make as much money as a man made in 2018. For African American women, that date was August 22nd. And for Latinas in the US, that date was November 20th. This is almost Thanksgiving. And you're still working to make the same amount of money as the man did by the end of the prior year.
And this is across professions as well, right?
So I think really this crystallizes for me the gender pay gap that we see, really. Is it, I was showing you this equal pay date as US data. Is it a US problem? Is it a US centric problem? Absolutely not. This is worldwide. And here we have a list of countries, and everyone has a gender pay gap. Some countries have it worse than others, but nobody's immune to the gender pay gap for sure. Now, when we look specifically at healthcare, I told you we were going to come back to healthcare and look at that gender pay gap. So this is looking specifically at healthcare workers. And if you look at all of the healthcare workforce, we see a 28% gender pay gap. People will say, yes, but women now, they choose to work less hours.
Right.
I said, okay, let's correct for hours worked. And this is that number you're seeing here, 21.1% gap. I said, yeah, but do they actually do exactly the same thing as men? And if we correct for similar occupation, we're still looking at an 11.2% 2% gap. Absolutely. So there is a gap, and we do have a problem in the healthcare. Now, how did we get here? How did we actually get here? Sasan, tell us how we got here. Explain to us what happened.
Well, it's an interesting story. So there have been quite a few frameworks that have been proposed to look at, well, what are the contributing factors to these, to these gross inequities, right? That are based clearly on gender. And so one of the frameworks used is what you may have heard of, the leaky pipeline framework, right? This is particularly used in STEM careers, so that's science, technology, engineering, and medicine, right? And essentially, the theory here is that it's essentially a metaphor for an observation, right? Where as you go into senior levels in that sort of career ladder, women just drop off. Mm-hmm. It's almost like a leaky pipe, and they just sort of drop off more so at increasing rates as you go up that career ladder, right? And again, it's interesting because in many places we know it's actually not a pipeline issue. It's not a flow issue, right? Particularly in medicine. Maybe in other science careers there is a bit of a flow issue, but for medicine, since the mid 1990s, we know that matriculants into medical schools have been essentially split half and half, right? So we have just as many medical students that are male as there are female medical students, and in more recent years, in fact, women have overtaken that proportion, right, in medical schools. But yet again, they're not seen in those senior levels. So there's clearly a leak in that pipeline. The next framework, which I think we started off our talk in our first slide with this broken glass, right? And that really was sort of an ode to this framework, which is the glass ceiling, right? So this has been more popularized recently with the US election results and so on. But the idea is that perhaps we're not seeing women at senior levels because there is an unacknowledged, invisible glass ceiling that they keep hitting that just stops them from rising beyond a certain level, okay? And the last framework I'm going to talk about, again, this is all terminology that I'm for those of you who are interested can go and look up and understand a little bit more, but I think the concepts are so important to talk about for today. The last framework is the sticky floor, right? So the idea here is that women who most of the time are occupying low paying positions and low mobility sort of circumstances are often not given the resources required to get them off that sticky floor to the next level, right? And those resources can be anything from administrative support, funding, flexible work hour options, whatever. The point is, at the end of the day, it seems that there's something that is just pulling these women down.
It was a great cartoon. I just want to interrupt for a minute and tell you about this great cartoon, because I think it really helped me understand this concept of sticky floor. It was essentially a man and a woman at a starting line. They were running a race. You had the start line, the finish line. And in between the start line and the finish line for the men, there was absolutely nothing. He could just run unimpeded and get to the finish line. For women, there were 8 hurdles in the way, hurdles with, one had the laundry basket, the children, the this, the that. And these are all the hurdles that this woman had to clear to get to the finish line. And to me, this really crystallizes what the sticky floor represents.
That's exactly it, right? And so the question becomes then, well, what is the underlying, or sort of the thing that underpins all of these frameworks, right? And the idea here really is the concept of implicit bias or unconscious bias, right? And the issue with that is essentially that we have sort of subconscious blind spots that don't allow us to see these inequities for what they are, right? And there's a lot to be said way beyond the scope of today's discussion about what implicit bias really is. But the idea here is that it's through those implicit biases that we have these errors of critical thinking, right? And these are real errors. You will hear these as women, as professionals all the time. So I'll give you an example. A very common critical thinking error is the idea of the perpetuating myth that, we just couldn't find enough qualified women to put them on that panel. We looked, but there's just none there, right? That's often just not the case anymore, right? It's often just not enough effort was put, or the social networks just don't include those women, right? So it's not about them not being there, it's that they just were not found, right? So that's a perpetuating myth a lot of the time. Another really important one is essentially ascribing fault almost to the affected group, right? So saying things like, maybe women just need to learn to negotiate better. It's just a skill set they don't have. That's why they get paid less, right? Instead of really saying, well, why shouldn't there be a transparent process by which it's clear what the skill sets are required for a particular position or job, right? So again, another critical thinking error. One that I hear a lot is the whole willful ignorance thing, right? Where men oftentimes will say, well, I didn't even really notice that. Really? I mean, I don't even know when they call me doctor. Really? Does that really happen? Right? So that's the willful ignorance piece, right? Which is, again, sort of devaluing the micro inequity, or sometimes macro inequity, that women are trying to communicate, right? And so having said that, I think we're going to hopefully spend some time. I see that we're running good on time. So we'd like to spend some time to talk about those biases, because I think they're so important. And for us to actually, that's sort of the beginning of trying to solve this issue. And I'd like to say, before I hand it over to you, Pascal, that these biases, again, are perpetuated by both men and women, right? So these are just so ingrained in our social cultural constructs that Pascal spoke to in the beginning, right? Where this is how we genderize, our world, the world around us.
So we'd like to explore some of those biases, and please, again, feel free to put in the Q&A your experiences as we go through them, because I know that a lot of people listening have had those experiences. Perhaps they didn't have a term for it, but now you will. So the first one that we're going to explore is what we call affinity bias. And I think the way to capture this best is in this example that I'm going to give you, which is you decide to mentor someone because they remind you of yourself. It comes from a good place. It really does come from a good place. You see somebody who reminds you of a young you, and you want to help them along. The issue here certainly within healthcare, is that a lot of the decision makers and a lot of the leaders are men. So if men only mentor people that look like them, other men, women never get a chance to get mentored and sponsored. And we know that mentorship and sponsorship is incredibly crucial to the professional advancement of everyone in healthcare, right? So again, affinity bias is one of the biases that we really have to keep in mind. And for men, in particular, the ones in position of power, to realize that that is a potential bias that they have, and that they need to look at people that don't look like them and to foster that talent as well. So that's affinity bias. Likability bias. So,
I got it. So likability bias is you need to smile more bias.
It is the you need to smile. And I'd love to have a show of hands. People tell me, how often have you been told, you really should smile more? So likability bias is we expect men to be assertive when they're leaders. So when they are indeed assertive, nobody is surprised. This is what we expect. But we expected women to be kind, communal, caring. So when they assert themselves as leaders, suddenly we just don't like them all that much anymore, right? And that is again a bias that many people carry, male and female, by the way. It's not necessarily one-sided at all.
Right.
And this is one example. And I know I am not the only person who has had feedback given on my speaking style. You're too loud.
Right.
You're a bit aggressive when you present there.
It's too high.
Yeah.
So you'll be surprised. I see that we have some men who are #he for she's in this talk today. And so I would question whether or not you actually ever, as a man, received feedback about your talking style, not related to content, but more, your voice gets kind of squeaky, or maybe you should just smile, or so on, right? So you'd be surprised at how often women get that feedback. And again, we would love for this to be interactive. So if you can just type in some of your experiences, that would be great, because we'd like to talk about them at the end.
Absolutely.
Okay.
So going back to the different biases that we have to be mindful of, I'm just going to go around. So maternal bias is one that we see often. Maternal bias is the bias by which we assume that women who are either pregnant or have children are not as committed to their jobs or to their work as other women without children or men. And what do we do when we have that bias? We don't include these women in initiatives, in projects that could advance their career, because we make the assumption that they're not interested, often without even asking them if this is something that they would like to be involved in, right? So that's maternal bias. And again, feel free to share your experiences of that. Attribution bias, another very common one. So you want to give an example?
Sure. So you're sitting in a meeting, you mentioned a good idea, it seems to fall on deaf ears, and then 10 minutes later, that same idea is said by your male colleague, and suddenly
it's brilliant.
It's an epiphany, right? And so, I mean, it's so common that actually, I think there was a New York Times article about this, right?
Yeah.
Where it was about the Obama White House and how women in the Obama White House, some of you may have read this article, noticed this and actually started amplifying their colleagues in meetings in order to just essentially give them the credit that's due, saying things such as, Dr. Pascal, when somebody else in the room says the same idea, to say, that's sort of following right off of what Dr. Pascal mentioned earlier. Yeah, I think it's a great idea, right? So that sort of deliberate amplification of female voices is one of the ways that you can think about dealing with attribution bias.
Absolutely. And then performance bias is essentially when you evaluate somebody's performance based on the group that they belong in your mind. So women are not as good technically as men in surgery. So hence you end up rating their performance lower, although they are as good and perhaps even better than their male cohort. So again, that is performance bias.
Can I just mention a study?
Yeah.
So there's a study that actually looked at that for surgical residents again, and they essentially looked at, how likely were trainees allowed autonomy in surgical procedures based on, again, looking through a gendered lens, right? And what they found was, even if when it was a female trainee, even if she did the surgery at the same level of proficiency, more efficient, did it well, she got less autonomy given to her by her supervisor. He was sort of involved more right, in supervising her directly than her male colleague, right? Even for the same level of performance, they went back and actually reviewed videotapes, right? And so the idea again is that this performance bias, again, is just, it's there. Yeah, it's there.
And finally, the last bias to be mindful of is really a combination. Is what happens if you have multiple, like what we call intersectionality. So you're a woman, you're a woman of color, you're a woman of color with children, and what happens is that those biases, they don't just add up; they actually compound at that point. So the combination of all these biases is worse than 1 + 1 + 1.
Yeah.
All right. So again, now that you have those terms, please feel free to share some of your experiences on the chat.
We do have a couple of comments here in the chat where I might ask some of these contributors to unmute themselves if they'd like. We have a few minutes.
Yes,
does anyone want to join in and
unmute
share?
yourself and share?
Don't be shy.
Yes. That is the beauty of live seminar or webinars, huh? Too shy to unmute yourself?
Okay, if they're shy, we can start reading.
Yeah, we can say what you've said.
So, wow, this is so true. I had a presentation recently and I was so scared. I thought I did pretty well, but I did receive 2 male feedbacks. It was all about style. And honestly, wait, I'm losing this. Hold on, sorry. All about my style. Honestly, I was put down. It intimidated me. That is such a valid point. It's not even funny. I mean, that happens all the time, all the time.
It makes you question yourself.
Here, another comment. When I didn't get the promotion I was applying for, a male colleague told me that's probably better for you and your family.
The classic one.
Yes, that's a great consolation, right? Yes. Again, can you imagine? Again, I want, I mean, it's really. Oh, we have a little. We have Abby's with us. Dr. Abby Spencer is on. Called heap eating. Abby, can you unmute yourself by any chance? Keep eating, I guess that's repeating, right? By men. No, it seems like
maybe she's not able to unmute herself. But thank you for contributing.
Right, so someone asked, what are our thoughts on explicit racial bias and also being a woman of color, implicit bias? My gosh, you sort of beat us to the whole double discrimination intersectionality bias, right? But yes, again, these are all topics related to exclusion, right, of different groups, right? Most of the time it's minority groups, but with gender, it's actually majority groups that are excluded, right? And so oftentimes in healthcare, at least, right? So yes, I mean, that I think it comes from very similar inequity mindsets that we talked about, right? Whether it's based on race, sexual orientation, gender, what have you, right? The idea is most of these implicit biases come from the same place,
yes,
right?
Absolutely, absolutely.
Okay.
And they compound, as we mentioned. They definitely do compound.
They do compound. Okay.
So if we move, we move, and we'll come back to your questions and your comments toward the end. I love this picture. And because really it brings home the point. So gender equity is, in my mind, it really truly a moral imperative. I mean, it's just the right thing to do, right? But beyond that, what happens when you actually have women at the table? What happens? Well, it turns out companies make more money. They're more innovative, right? It becomes better for everyone. Right? It lifts all boats. So it's really important for me to share the fact that it's just not the right thing to do just because of the morality of it, but it truly does advance your society and it makes your systems better. It makes you more productive, more efficient. It works better for everyone if you have women at the table. This is another picture. This one I find less funny. This is from 2017, a bill on maternity services. I do not have to tell you what is wrong with this picture. You can see it for yourself. But again, what happens when women are not sitting at the table, right? What happens, Bob? Bad things happen when women are sitting at the table.
Without getting political.
Can I tell the Snow story? Okay, so I'm Canadian. So snow is a big part of my upbringing, obviously. And there was a study in Sweden. So the Swedish government had this mandate to look at all their initiatives through a gendered lens, right? And they looked at snow plowing. And I remember reading the study and thinking, how could snowplower be genderized? I mean, what does it matter? They will find nothing, right? Well, it turns out the committee that was in charge of snowplowing in that little town in Sweden was made out of men. And what they decided was that they're going to clear out the big streets and the large arteries and highways before doing the small streets, right? And we've known, and the data has been very clear, that women tend to use public transportation more and tend to walk more to places. And most women don't go from A, work to B, home. They go from A, work, to B, pick up the kids, to C, pharmacy, to D, grocery store, and then finally they get home, right? They do those multiple trips within trips. And what was happening is, because they tended to use they were shorter distances, use smaller streets, they tended to fall on icy pavement. And when they looked at the data and realized how much they were spending on fractures and other healthcare costs from all those falls, they ended up changing the way that they plowed the snow after a big snowstorm, and ended up saving a significant amount of money on a healthcare cost. And it did not worsen the conditions of people driving on the larger streets either. So the snow plowing, and I know Southland is rolling
about 2 minutes.
It's just rolling our eyes with the snow plowing example. But really, I think to me brings home the point that it is really important to use that lens to look at everything we do, because we can really improve entire systems if we use that lens.
I mean, yeah, I was being facetious. Of course, it's a great example of just systems improvement, like you said. When you look through a gendered lens, right? When you're looking for these implicit biases. So then the question is, well, how do we do this? What do we actually do? So we've mentioned a few things along the way. So some of this might be a little bit repetitive, but there are a few things you can do. So some of you may have heard of this. This was a really big thing. The head of the NIH, Dr. Francis Collins, came out about a year ago and said, look, I am just not going to condone this anymore. I will not sit on science panels that do not have women, right, represented. And that is such a powerful thing to do, right? With particularly an individual with so much credibility and experience and sort of and visibility, actually, right? Mm-hmm. So the idea is, that's one thing people are doing, taking a public stance, right? Now, if you're not Francis Collins, there's still things you can do that would be really helpful. So the first is, again, and we repeat this because this is, what you need to do is have a paradigm shift in your thinking to say, this is not a female issue, right? It is not a female issue, and it's definitely not a male-female adversarial issue, right? So the first thing is shifting that paradigm to look at this and say, this is a systems issue. This is a power differentials issue. This is an issue that has real measurable impact on everyone, right? And so how do we do this more consistently and deliberately? Yeah. That's the first thing. The next thing you can do very easily is you can amplify the voices of your female colleagues, right? Yes. And this is not necessary. You would decide when it's necessary and when it makes sense, right? But the idea is just being more cognizant of, maybe that thing that was said earlier in the meeting, I might just sort of echo it again, right? Just to make sure that everybody feels included in this conversation.
As Dr. Southland mentioned earlier in the meeting, this would be a good initiative.
Right.
Absolutely.
Absolutely. Being, again, very observant of gender balance, right? In the places where you do sit. All of us are leaders in some way or the other, right? We sit on committees, we sit on task forces, we run projects, right? Whatever it is within your discipline, always sort of ask yourself, where are the areas, is there good representation here of both genders, right? And what can I do to improve that?
Absolutely.
The Gulf. Yeah. So the Gulf icon. So this is a real issue, guys. So as you know, oftentimes within professional settings, there are social opportunities to get to know your bosses, your supervisors, right? And oftentimes those social opportunities, by definition, by their nature, exclude women. So the classic is sort of the golfing, right? So the boss that golfs on weekends and you see the male direct reports every time they golf and they rub shoulders, right? And then the woman is sort of wondering why that person had a promotion much quicker, right? So the idea is that, making sure that there's as equal access as possible if you're the leader to you, right? particularly in a social setting. One of these CEOs, I remember I read this a while back, essentially noted that, one of the things he was doing was taking his direct reports out for dinner, right? And he realized that is probably exclusionary, right? Because one, not only is, dinner time oftentimes the time that's just not accessible for many women, but even if it were, that social situation of going out to dinner, young woman with your sort of older boss, right, has, maybe connotations or implications that she'd like to avoid, right? So just being cognizant of, well, you know what? And I think he said specifically, I will be instead taking out my direct reports to brunch, right? So moving those types of opportunities from dinner to brunch.
Very good.
The next thing that you can do as an individual is, again, just to speak up about it, right? To talk about it more often, right? To make comments. The other day, one of the leaders in our organization actually did a wonderful thing. He rode the elevator with me and said, I just want to tell you, I'm sorry. And I said, for what? And he said, well, I was sitting, I noticed in this last meeting, everyone was introduced as doctor, literally except you. And I don't know what to say. I mean, that in and of itself is great, right? Because then if people are just observing and saying they're observing these things. So even if you're not, necessarily saying it to make direct change, but just acknowledging it and being cognizant of it is really a step in the right direction. Letters of recommendation.
We're
right?
back to that.
Back to that. So wording.
Yeah.
Maybe make like I said, a do not use list of verbiage or vocabulary that you're just not going to use, right? Whether it's male or female, right? And being more focused on really those marketable, competency-based skill sets that employers really want to hear about, right? And then lastly, sponsorship, right? Sponsoring that next sort of generation or your younger peers and colleagues, right? So, and I'd like to just take a quick second and sort of delineate the difference between sponsorship and mentorship, right? So, mentorship is really important, and it's a great opportunity to have a one-to-one relationship with an individual who you might gain some advice and experience from. Whereas sponsorship is that person who talks about you when you're not around, right? Who doesn't just say it to you, but sits on meetings, and that sponsors, again, usually somebody who's in certain circles, professional circles, and is able to say, you know what, I think Pascal would be great on that project. What do you guys say, or what do you think? Or that individual who just literally allows you to use their sort of, ride their coattails and essentially use their experience or their circle to advance yourself professionally, right? So that's different from a mentor who may give advice, right? So being a sponsor is a little bit more sort of an active role. And again, that's something that you can easily do to advance female colleagues. So what can you do as an organization or as a leader, right? First thing, just stop the manuals. Stop the manuals, right? Make sure that you have, that whether it's selection committees, whether it's promotion and academic promotion committees, whatever it is, just make sure you have, some level of gender balance, right? And again, preferably really that level should reflect your workforce, right? Yes. And so really a real commitment, not that one woman right on that panel, but a real commitment to gender balance. The second is discussing equity within your team, gender equity issues, and not discussing it only with women, right?
Very important.
Super important, right? So discussing it with the men on your team, discussing it with everyone, having a sense of, well, does this work environment ensure a balanced experience for everyone, right? I'd like to hear about that, right? And asking those questions actively. Challenging the structural barriers that you do find for the advancement of women, right? So quite a few structural barriers that we know do exist in institutions, right? That you find and just challenging them. Well, does this policy allow for access really for everybody to these interviews? Do we have a recruitment strategy that ensures that we're getting out there and whatever those barriers might be, challenge them actively, right? And then I know this sounds a little crazy, but creating a gender action plan, right? as an organization, which actually means all you're doing is reporting on data and specifically breaking it down, looking at gender, right? And that data might be on pay and funding and, in facilities and administrative support, whatever it is. But creating an action plan within your organization to say, we're going to look at this moving forward more deliberately. So I'd like to say we're actually lucky enough to be part of an organization that really, one, sponsors these types of talks, right? Which in and of itself says a lot. But two, has actually signed up to the Times Up Healthcare sort of movement. For those of you who were following this is sort of an organization that looks specifically at sexual harassment and gender discrimination in the workplace, and essentially saying enough is enough. Time's up, right? Zero tolerance. And so this is a copy of, our CEO's essential, commitment to this mission.
Yeah, absolutely. Important. So we've come actually to almost the end of our talk here. We could not close without sharing this quote from the recently departed Supreme Court Justice of the U.S., Ruth Bader Ginsburg, who said, "Women belong in all places where decisions are made." And I think this is truly the bottom line of our talk today on equity. If women are not sitting at the table, you're missing out. You are missing out on an entire different way of looking at issues. So it is important for systems, for societies to be inclusive of women whenever decisions are being made at every single level. It's really very, very crucial.
Right, and that's really the bottom line, right? Is just to ensure that we're there when those decisions are being made, right? That's really the bottom line. So
we'll close with this is our last slide, and we wanted to intentionally leave a few minutes for discussion. We said at the beginning again, our webinars are really meant as conversation starters. And tonight we've started this conversation with you on gender equity. Please feel free again to either unmute yourself to contribute or put a question or a comment in the chat. We would love to hear about your experience, if it's something that we've mentioned here today. If it's not something that we've mentioned, please feel free to share with us as well.
Yeah, and we'd like to also just take a second and say that we're hoping to have these types of discussions on a quarterly basis, and all of these discussions are going to revolve around issues of women in health. And again, we would like this to be seen as a very inclusive conversation, right? So the idea is that we would be talking not only about, clinicians, but really all women in healthcare, right? And what are the common opportunities? What are some of the common barriers, challenges? What are the things that we should be looking at when thinking about women in health?
So we want to look at it from multiple different angles, and that's sort of the goal of this series that we're starting today. So let's see in the chat here.
Yeah, so there are a couple of things here in the chat, but as well, if anyone wants to first unmute themselves and give us comments, feedback, ask a question, share an experience.
Please feel free to do so as well. Well,
I have a comment, if
please,
I may.
Go ahead.
Dr. Pascal, Dr. Sassan, thank you very much. It's Laila here. It's really been
Laila, how are you?
wonderful discussion. Thank you very, very much for putting this together and for a very exciting webinar. All what you said is great, and all of it is true. I just wanted to add one thing more, is for all of us not to be shy to take any initiative on. Just be brave, go for it. Just do it. As Nike motto said, just go for it. No matter how small or how intimidating the task may look like, just go for it. Give it your best shot. Don't be afraid of taking chances. And the more you do so, the more you're gonna enjoy it.
Right. No, you're saying something that's so important. I mean, for us, even this type of webinar was a huge leap for us, right? We're not technologically savvy. We had a lot of trepidation about this, but the idea is, you're right, just leap forward. So there's actually some studies looking at the likelihood of women to raise their hand. That's what you're saying, is essentially when there's like some new initiative and they what is the likelihood that a woman will volunteer or raise her hand and say, okay, I'll lead this? And of course it's less. And it's funny because the whole, if I remember correctly, it was about at what level of experience and knowledge she has to get to before she raises that hand, right?
High.
Really high. So, so it might be right up her alley, and she'll still be like, well, I'm not really sure if I should do that, right? Whereas again, that's not so much the case oftentimes with men. Not to generalize again, but the idea, as you're saying, Dr. Leila, is just to take that jump, right? That's one of the things that can be done for sure.
Report. Thank you. That's such an important
Thank you.
point. Thank you very much. Absolutely.
I see a comment here. I'm curious if any U.S. hospitals have made a gender pay equality or female representation in leadership goal and published on it. The answer is yes, actually. I think it was the Mass General, right? So they did actually a really sort of brave thing where they decided that they would sort of be transparent about their recruitment and compensation sort of practices, and sort of put it out there, and they actually published on it. I'm happy to share it with you, Nicole, actually afterwards, and we'll send it around. But yes, there's absolutely some data on this. Not a lot though.
But what does that do for them? The people that actually do that, it increases. I mean, it's fantastic for their institution, right? It raises the level of their institution and allows them to recruit even better people. So it's a win-win situation there.
Yes,
absolutely.
Someone asked, can you give me more examples of likability?
Of likability bias. So again, just to remind everyone, the likability bias was the you need to smile more bias, whereas women are not thought of as, it's thought as not appropriate for women to be assertive in the way that they conduct themselves. And people start to like them less. So it's you going up to your boss to ask for anything, to ask for more funding, to ask for more protected time, to ask for all sorts of different things, and it being said, well, you know what, I thought she was nice, but turns out she's just quite aggressive. Turns out she's quite bossy. So bossy, another term that comes back a lot to describe assertive women. Women are bossy, men are assertive. So again, these are examples, but if you keep your eyes open, you will see it a lot. You will notice it a lot. And I think that's true of all the biases that we've discussed today. The more you know about them, the more you see them, sometimes in microaggressions, as Salsa mentioned, but sometimes in macroaggressions as well. And it's important when it happens to you, but it's also important to be the witness when it happens to someone else in front of you, and to be able to recognize that and address it as well, right? Thank you for the question.
Another comment is I've always been told you need to look for a part-time job, more time with the family. Even my wife and his wife has also taken many breaks for kids and doing part-time job work. I think the comment here is essentially, again, being advised. That's the maternity bias, right? Being advised that, oh, this is what's better for you, right? And so on. So I think someone was trying to unmute themselves, right? I heard a little noise there.
Hello, can you hear me?
Yes.
Hi, this is Jihan here. Thank you, Dr. Salsa and Dr. Pascal's great talk. We all needed to hear the stuff you just said. Because, so I just have a thought, I'm not sure, and it feels a bit anecdotal, but because you also were saying that most of your data come from the West and the US, and I was wondering, is it because also these how do you call it, these systems has been set in such a way for a very long time? Because what I've seen, for example, in Sudan, where I come from, is that men and women started to, be educated maybe more or less at the same time. They had the same rights at the same time. And I was wondering, maybe because they kind of started at the same time, we don't see that bias as much. So I'm not sure if you have any data in African countries or also Arab countries and as such. And just one question is how much of this gap is also caused by other women? There is the myth of, it's like I'd rather have a man as a boss than a woman, because they also kind of, how much, are they also causing or telling off their peer or their colleagues Just,
Yeah.
I don't know, just a thought. And I was
Those are
wondering.
great thoughts. Those are great thoughts. Which one do you want to
No,
take?
these are great comments. I think in terms of the data, I mean, you're right. The data we presented is very Western centric because that's the data that's out there.
That's actually-
I'm right. We don't have data looking at Sudan or looking at other African countries. We just don't.
Right.
The theory that you're postulating, which is, well, maybe there's less of a gender equity gap there, is possible. These are things that, again, we can only hypothesize.
But she's right in the sense that what she's asking is, because these differences just haven't been as entrenched, right? Because it's just historic sort of time periods, right? Is it possible that they just don't exist as much, right? And as you said, we just don't know, right? We don't know. I know that anecdotally, cultures here have provisions actually in terms of sort of HR rights of women, more so than even Western countries. So it's interesting, but I don't think we have the data to be able to say that they're inclusive. The second part of the question is the queen bee, right? So what you're actually describing is called the queen bee phenomenon, which is that there can only be one queen bee, right? And so the idea is that someone put it for me nicely, well, I don't know nicely, but said somewhere around the line, sometimes women make the worst men, which is another way of putting it. But that, is it possible? And that has actually been debunked.
Yes, actually it has.
It has. So not to say it doesn't happen, but it has been debunked in the literature that this is less likely the case. In fact, it's another perpetuating myth that we talked about. So the answer is not that it doesn't happen, but it doesn't happen as much as we may think that it does. Oftentimes, what the literature shows is those queen bees, what you see as a queen bee, is somebody who they themselves are so dispossessed and powerless that they don't have the same level of power, I guess, and authority as you might think they do if you had a male boss, right, who would have had that. So it sort of perpetuates downward. That's the new theory, rather than saying, well, it's just an innate thing, if that makes sense.
Yeah, no, it absolutely does. Thank you so much for your very interesting comments and questions.
Yes.
We're rounding up to 8 o'clock.
Yes.
And unless you have a burning question that came up on the chat, I would like to say that it's been an absolute privilege to have all of you here participate in this first webinar that we've had today. This again, and I'll repeat it, is the beginning of a conversation. We will have more webinars in our Women's in Health series coming up. And again, we'll be looking at different angles around the same theme. Thank you for your time. Thank you for your participation.
Oh, thank you so much for your thoughts and your contributions.
For being a wonderful co-host.
Yeah, so we really, really enjoyed it. And I see that there's still more comments coming in.
I see they're coming in now.
So thank you for your engagement.
Thank you.
So have a good night.
Good night to all.
Bye-bye.